Well, on behalf of Hospice of the Piedmont and Hospice of Randolph, welcome to the E-Series, an educational webinar series aimed at engaging our community, exploring relevant topics, and educating about ways to connect with our organization. My name is Ryan Biagini, Director of Community Engagement and Education, and I am your host. Over the past several weeks, our E-Series has continued with a sequence of conversations highlighting the care we provide the patients and families we serve. Joining me for today's session, Conversations in Care, Working Together, is CEO Trent Cockerham and hospice nurse Lynette White. By now, you are all no stranger to Trent. Trent joined Hospice of the Piedmont in 2013 as the organization's third CEO since its founding in 1981. Prior to joining the organization, Trent worked for 16 years in long-term care with Triad Medical Services in Yadkinville, overseeing operations and management of a statewide network of almost 2,000 long-term care beds. Most recently, he led the organization in navigating a successful merger with Hospice of Randolph. Thanks for being with us again today, Trent.
My pleasure, Ryan.
Joining Trent today is Lynette White. Lynette has been working as a nurse for the past 12 years. She began her nursing career as an LPN working in long-term care before returning to school for her RN license. Lynette started with our organization in 2014 and has continued serving patients in Randolph County and the surrounding communities ever since. Thank you both for being with us today.
Thank you.
In just a moment, we will get the opportunity to sit in on a conversation between Trent and Lynette as they discuss how the team concept of care offers great opportunities for success, not only to eliminate boundaries for individuals receiving care, but to create unity across the entire care team. During today's discussion, if you have any questions, please type them into the Q&A section, which you will find at the bottom of your screen. We will set aside time to address these at the end of the session. You may also choose to type any additional comments in the chat section. Now, without any further ado, I hand the discussion over to you, Trent.
Thank you, Ryan. Lynette, I so appreciate your being with me today for this conversation. You know, as I was thinking about what we might talk about today, as Ryan introduced you, it's clear you've worked in a lot of different settings, a couple different settings at least. Mm-hmm. What led you to hospice?
A couple of experiences, really. The first one, when I worked in long-term care, I was working one evening and I had a patient that was very near end of life. So I was making frequent checks on the patient that night. And I went in one time and he opened his eyes and he took my hand and he asked me, he said, "Please don't leave me alone." And that touched my heart and just made me feel like, you know, just my presence being with someone when they're where they are at in that process. I felt like, you know, I could do this, I could help someone else along the way. And then that, on a more personal note, was an experience that I had with my dad. Now this was like 22 years ago or so, give or take. My dad was diagnosed with non-Hodgkin's lymphoma. And he was having treatments and we had been in and out of the hospital a couple of times and we were at the hospital at this point. And I had went up to visit with him and I had told my mom to go down, get something to eat, take a break. And I had fed my dad supper that evening and we had talked a little bit. And I was sitting in there with him when the nurse came in and they did their thing and they called me outside the door. And they told me, you know, if there's any family that you need to call, now's the time to do that. And then went on to say, you know, it could be 2 hours, it could be 2 days. They just didn't know. Nowhere in that process of my dad being sick had I ever had any communication from anybody that we were that near the end of life with him. I felt stunned when they told me that. I just stood there and I was like frozen. I
You
felt
were a nurse.
alone.
You were a nurse, right? At this point.
I felt alone, and I felt like the whole world had just caved in on me. Um, and the nurse, I know they were working on the hospital and they had other things to do, but there was no compassion. There was no help for me at that point, I felt like. So I knew then that hospice, I wanted to be there so that no one else would ever have to experience an end of life process like I did at that point.
Wow, that's an incredibly powerful story. I appreciate your sharing. I mean, you were a nurse at this point, right? I mean, so you had all this knowledge, but you were still yet completely unprepared.
Actually, no, I was not a nurse at that point.
Okay.
That's kind of what led me in the direction to go into nursing.
I see. Okay. Wow. Well, so it sounds like, Lynette, you've seen sort of two different sides of how, not only do people live their lives, but what end of life looks like for people. Um, it sounds like you have a personal draw to the work that you do in hospice care. Is that a fair statement?
That's a very fair statement. I feel like what I do is a personal passion for me to be able to help those that I come in contact with. I'm a person is never prepared for end of life. They're never prepared for losing that one that they love. But just being able to be in the homes with those people when they're experiencing this process, and by being able to teach them the things that I wasn't taught at that point, being able to mentally prepare them for that. Even though you're never prepared, you can always continually teach what's going on with the patient so that they know that what to expect when the end comes. So they're not shocked and they're not feeling alone like I did.
Sure. So, one of the things that you just said sort of makes me think about how we tend to want to apply sort of a formula to life, right?
Mm-hmm.
How life sort of happens at predictable moments. Like there are a few things that are predictable in life.
Mm-hmm.
Two of those are bookends. One, we are born,
mm-hmm.
And then the second one, we die. And there's a lot of life that happens between those two bookends of life. And so, as we try to make sense of this, as people who are watching this may be thinking about calling our organization or thinking about needs that they may have or that they may have personally in their own family or for people they may be connected to, I'm curious to know your thoughts on, how do we apply the same sort of concepts to be able to fit into people's expectations of how life happens, right? Because realizing no two care experiences are identical.
No two are ever identical. There's two memorable times in people's lives. We always remember a birth and we always remember the loss of a loved one. So to fully answer that question,
it sounds like what we're talking about is sort of, as we think about how different people experience different points in life, and how what I know about what we do as an organization is you are the sort of the qualified expert at the bedside, right? And so I suspect you spend a lot of time sort of preparing patients and families for the next series of events.
Yes. When I'm in the home, I'm looking at the patient, but I'm not only looking at the patient, but the caregivers and the families as well. And during that time, I'm preparing them in a way so that they know what to expect next. And that's where I pull out my When Death is Near book.
Mm-hmm.
And I'm teaching those signs and symptoms that they can look for that kind of can help them understand where they may be in the process. Not only that, but just being able to carry on conversations and listen to the family and to the patient. And you find out what's really going on in the home. And when you do that, then you're able to pull in, other disciplines to help with some of those things that's going on in that home. So, there's a lot to giving care in the home. And a lot of that is just being able to listen, to be able to show that passion and that being the companionship for them to, in other words, to kind of hold their hand through this process so that they don't feel alone.
And I suspect that feeling of alone is not just the patient. You're talking about all the people that are surrounding the patient too, right?
Mm-hmm.
So Lynette, you mentioned part of a team. You work as part of a team. This is the now fourth installment of this Conversations in Care that we've been having, and folks who've watched previous episodes of this of our Conversations in Care series have heard from Joanne Scott, one of our admission nurses, have heard from one of our social workers who also has a master's degree in divinity. So they've heard about the spiritual and psychosocial dimensions of care. So talk a little bit about what it means to work as a member of a team from a nursing perspective.
Okay, so, to work as a team, you have to kind of focus on who's leading that team. And in hospice care, it's really the patient that's leading that care. They chose hospice as a pathway towards that end of life process. So when you're focused on that patient, like at the admission, it all starts right there. A patient will get a doctor, a nurse, and a social worker. And then you have the options to get a volunteer, an aide. And then, whether or not you take those, when the rest of the team is in that home and we are building a relationship, we're building that rapport with the families and we're earning their trust, then at some point down the road, there might be something that's happened or going on that we say, hey, well, this might lead us to think that a volunteer or an aide might be helpful in that home to help them through this process. So as a team, we're all working together because we kind of know what the patient's goals are towards the end of life. Most of the time those goals are something like comfort. They may not want to go to the doctor anymore. So as I'm in the home, even though those are pretty much the typical goals that a person sets to begin with, because they really don't know what kind of goals they want at that point. And then as I'm listening to them in conversations, I pick up on little things and I say, well, this might be helpful. I remember one patient in particular that I was in the home, and she was actually at her daughter's home. She had been unable to care for herself for quite some time. And so when we come on board, I was able to talk with her, and in conversation, she's told me that she wanted to die in the home that her husband had passed in. So, that led to more conversations with the family. And so we got to talking and we started to develop a plan. Now, it was not only me that was able to make all this become accomplished. It took the family, it took the social workers, it took people behind the scenes, people that were in the office helping to, schedule some of this stuff to happen, because this family's home, or this lady's home, had been pretty much closed down because she was living with her daughter. It was unlivable. The power had been turned off, the water had been turned off. So I was actually, as a team, we were able to guide them. Okay, we need to start working on this. If we're going to make this happen, we need to go ahead and start working on this, kind of a timeline frame. And so with the help of the team, we were able to get that accomplished for this lady. And I'll never forget the night that we took her in her home and we allowed her to actually lay in her bed that night, her old bed. And the smile that come on that lady's face it meant more to me than anything at that point. And so that's how the team kind of works together. We're focusing on that patient, and then we go from there. That's the reason everybody's plan of care is different.
So when you think about, when we talk about plan of care for folks who might not be medically inclined, who might be watching this today or later, you're really probably talking about an exploration, I suspect, of their needs, wants, and priorities. It's a concept we talk a lot about in our organization, right, with our patients and families. Do you find, and I think you alluded to that, but I just want to explore this a little bit more. Do you find that those things change over some span of time?
They change almost with every visit. They can. I remember having one patient, and I went in to see them that day, and the caregiver, she just was so tired. And I said, "What is going on? Are you not feeling well?" Because, the caregiver, the one that's caring for that patient most of the time, I need them well. I need them to be able to help take care of that patient when we're not in the home. And so she shared with me that she had not been sleeping well. So at that point, I started the conversation, maybe we need to add a volunteer. She said, "Well, what can they do?" And I said, that volunteer can come in here and just be a companion with the patient, and you can go upstairs and take a nap. And we implemented that, and it worked out wonderful for her.
You saw it almost immediate difference.
I did. She felt, the next time I saw her, she felt replenished. She felt like she could carry on the day. Another, for instance, I had another caregiver that there was no family. Her children had passed, and she was caring for her spouse. So she was having a hard time just going to the grocery store or going to her own doctor's visits. And so we got a volunteer to come in the home, and that allowed her enough time to do those things. Also giving her a break from the patient by just being able to get out of the home and do those things.
So, you've hit on a couple things that I think are really impactful for folks who may be watching this either now or later, or listening to it at some time in the future. Is that you're a nurse, and you're going into a home, and people, when we interact with a nurse in healthcare, we're expecting a nurse to do the things that nurses do: take our temperature and check our blood pressure and measure our respirations, right? Those
Right.
are sort of normal expected things that a nurse would do. And we would consider those in healthcare to be vital signs, but you're talking about vital signs that are incredibly a tremendous departure that really aren't even related to the patient.
Right.
So
We are in the home just as much for the family and the caregivers as we are for that patient. Because this is an intimate time. This is when the whole family is surrounding that patient to care for that patient. So I'm looking at the whole family when I'm in the home. Is there any conflict that might be going on? Can we help there? And that's when I might pull in a social worker, or sometimes at times I've even had to plan family meetings because siblings was not in agreement with maybe what the caregiver was actually, how they were caring for that patient. And I remember one that, the patient had declined and they were getting very near the end of life. And so all these symptoms were showing up, and so we had to start using some of the comfort medications. When the caregiver started using those medications to keep the patient comfortable, the daughters, they didn't like it, and they were actually giving the caregiver a hard time during that process. And so I offered to talk with the daughters, and I did at one point, and it really didn't help that much. So then I collaborated with my team, my social worker, the doctor, the director of patient services at that time, and we all planned a family meeting so that all the family could come in that home and we could discuss everything. We allowed them to discuss their fears, their concerns, to share their feelings about what we might be having to use here. So during that meeting, everybody, we listened to them, we explained why we use these medications, and everybody come to agreement that, let's keep Dad comfortable. That's what we want. So the team helps in that kind of way too, when there's family dynamics going on.
Sure.
And they're a great support to me as well as they are the other families.
So that's it. That's interesting. So you draw support from your own team members.
Yes, sir, I do.
Yeah. Wow. Well, so you mentioned something about fear. And I suspect, Lynette, in the time that you've worked in hospice care with our organization, you've cared for many, many patients and their families. I suspect fear is not an uncommon emotion that people have when you're first meeting them, right?
No, they fear the unknown. They fear what what visits are going to be like when we come in the home. Some families have shared that, are we looking at how they live? Are we going to turn them into, someone? And I kind of ease their fears there, and I say, you have no worries. I'm here for you. I'm here for the the patient. I'm not looking at all that stuff. I'm just here for your emotional support. I'm here for the patient's physical, emotional, mental, all those, the whole picture, the whole person. That's what I'm treating when I'm in that home.
I'm sure along with that, you probably get, it sounds like what you're describing, what I know to be true, is that you're part caregiver, part teacher, part nurse. You're sort of pieces and parts of all of this, right? And you have a team that supports all of those things too. That much is clear. But do families ever ask you, or do they ever begin a question or end a question with, I bet you've never been asked that question before, or has anybody ever asked you this, right? I mean, does that happen, and how frequent is that?
That's almost with every patient that I've ever served. Sometimes it might be something as personal as, constipation, something that people don't like to talk about. But the biggest and most common one that people will ask, and they'll say, I know you get asked this all the time. Um, and I know so tell me, what's the time frame? So that's a big, big question that families want there. And that's when the teaching part of the nursing comes in, and I'm able to kind of guide them as to where we may be in the process.
Right. And so part of what you're doing too, I'm sure, is helping normalize those conversations and letting them know, because most of the time my experience has been, I know for me personally, if I'm asking that question, it's because I want some affirmation that people are asking the same questions that I am, because nobody wants to ask the outlier question, right?
Right.
Yeah. So you're really helping them normalize really what they're thinking about and what's on their mind. Um, Talk a little bit about, if you could, you know, you you've worked in a long-term care facility. You've had a lot of nursing experience in your career. Working in a home is really different, right? You're also working with people who are not, they're not oftentimes, most of the time, I suspect, they are not professionally trained caregivers like you. Talk a little bit about what that's like.
Working in the home, it you actually have the experience is more personal.
Hmm.
Uh, Families will often share more because they're in their own personal environment. And so, once you're in there and you've built this rapport and this trust, and they depend on you to be there for their needs, they open up, they share more, which in turn helps us as the team care for that patient, care for that family, care for that caregiver. So it's a little bit different than being in a healthcare setting like long-term care. When I was there, that was more task focused, I guess, because you had a shift and you had tasks that you had to complete. You didn't have the time to really sit down and have those personal, intimate conversations about, about end of life or anything. And in the home, I'm able to, kind of kind of break down that wall a little bit so that families are a little more comfortable talking about the end of life. And I'll expand here too to say that most of the time, like we all are, most of us, unless we work in hospice, death is something that no one wants to talk about. Um, so, I kind of compare it to walking in a room and, the patient's near the end of life, and here's this big elephant sitting here, and and nobody wants to acknowledge that elephant. So that's when the teaching comes in. That's when compassion comes in. You're breaking down that wall, that barrier. I'm sorry, to allow the family to explore what's going to happen next. To prepare them for what's going to happen next.
And I think we can all acknowledge that talking about death is something that is difficult for most anybody. And when we're suddenly faced with it, it does become sort of, as you describe it, an elephant in the room, and it is something that we have to talk about. do oftentimes you find that people may find themselves in a, you know, they're hoping for something different. And you have to, then you and your team have to sort of bridge that disconnect, right?
Mhm. So, you know, a lot of times families are often in denial. They're hoping for the patient to get better. Um, so that's when, you know, we continually teach, and I tell my patients and I tell my caregivers, you know, it's okay to have that hope that things might turn around and get better, but let's keep it realistic here. Uh, you know, if this process continues the way that we think it will, then I want you to be prepared for what might happen next. And it takes a lot of listening to people to get them. Like I have one patient now. Um, you know, things are changing here, and the caregiver, she's every time I go, she says, I still have hope. And I say, that's okay. It's okay to have hope. We can all pray for things to turn around, but in reality, this is what's going on. And a lot of times I will, um, instead of me kind of carrying on, you know, telling them what I see, I'll start the conversation by saying, tell me what you're seeing. What kind of changes are you seeing in your pet, you know, in your loved one this week? And most of the time they're seeing the same things I am. They're just not wanting to admit it. So that's where, you know, just being there and giving them that support that they need during that time. And that's when I draw the other team members in here too. You know, I often will call a chaplain and say, you know, we might need a little extra support here. Things are not going very well, and the family is still kind of in denial. Even the social worker, I bring them in there to help with that as well. So,
You know, you mentioned something that is sort of interesting to talk about is this concept of better, right? Oftentimes we think of better as cured, but I suspect better in the context of working with someone who has a long-term chronic illness, or perhaps a sudden onset of a very serious illness. Better is a relative term, right? And that, I suspect that concept of better also informs or changes those needs, wants, and priorities, right?
mhm,
Is that fair?
that is fair. Yes.
Yeah. So, you know, people have a hard time, Lynette, sort of thinking about hospice care, and oftentimes think about, I think you've sort of alluded to some of this. They think about hospice care as the difference between curative care and doing nothing, when in reality, it's about how you organize your life to have a more fulfilling life experience for whatever time that might be. Has that been your experience in working with the patients that you've cared for?
You know, I've had a lot of families tell, when I first go in, especially tell me that, or, you know, the patient may be developing symptoms of, you know, an upper respiratory infection. They might be having a fever. Well, there's nothing y'all can do for that. We're on hospice now. Um, and, you know, I kind of explain to them that, you know, treating those symptoms is actually a comfort, because if they're having trouble breathing, that's why we're here. That's part of why we're here. When they have those symptoms, we're helping to alleviate those so that they can have a better quality of life. And oftentimes when we do treat those little symptoms, or even just treating the symptoms that they have when they come on, whether it's difficulty breathing or it's the pain, whatever the symptom may be. When we get those managed, a lot of times their length of stay increases, and we're able to serve them much longer.
So I'm curious, about that. So length of stay, for those folks who may not know what that means, is just the duration of time that people are in our care. Lynette, I suspect in the time that you've worked within our organization, you've cared for many patients who had varying lengths of stay, from incredibly short, maybe hours to days, to maybe even months, if not years long. And do you find that their experience is different, not less fulfilling, but different? And how might you characterize that?
So I have had several that, I may have a day. I've seen them one visit. I still give them the same care that I do when I have one that I have longer. You don't have the time to make that personal connection and maybe pick up on some of those things that are important to the family that they would have liked seen happen before the end of life. So when you have someone that's, for a longer amount of time, whether it's, 6 months or a year or whatever, families open up more, they share more. And so you're able to build and develop a plan of care based on things that continually change during that time. Yes, the plan of cares change when the patient's symptoms change, but we're also we're also caring for the family. So that's what I'm talking about there. We're able to pick up on more of that. But the care is actually the same. I give every patient that I ever am privileged to take care of, I treat them as I would want to be treated. So the care is the same.
Yeah. So you talked a little bit about symptoms here and there throughout our conversation. And, it's not difficult for people to understand physical symptoms like pain or shortness of breath or nausea, right? But there are other symptoms too that patients experience. Can you talk a little bit about that and how you sort of engage the team for those kinds of things?
Okay. The one that pops up right now is, emotional. That's a symptom. I have a patient right now that I've had for a little while, and he's starting to progress, and he sees it, and he's starting to get a little anxious about the end of life here. And so when I go in, he's talking to me, and he always asks me, what can I expect next? So at that point, I was able to call the chaplain and say, a little bit of anxiety here about the process that he's going through. And, I talked with him, I gave him as much compassion as I could at that moment to relieve his anxiety. But he also needed that extra support from the spiritual aspect of that. That's another emotion that a lot of people have difficulty with, is the spiritual aspect, because a lot of people are spiritual. And, I remember another little patient that I had, and every time I went, he always told me, I'm ready to go. And I was on call that night actually, and got called out to the home, and he was having some respiratory distress. And we had changed medication several times that night, and I went over to be with him and give him some more medication. And he looked at me and he told me, he said, "I'm scared." And so I had the conversation with him. "What are you scared of?" He said, "I'm not so sure anymore." So at that point, middle of the night, I could have called a chaplain, but I'm there at that moment. I didn't know how long this patient was going to make it. So I was able to sit down on the side of the bed with that patient and hold his hand and help him pray. And that relieved his anxiety and scared feeling that he was having at that moment.
So, well, I mean, these are powerful stories, Lynette. I mean, you know, as you think about working in a team, which is it's something that's a little bit unique, I think, to hospice care. Um, when you think about working in a team, um, what is it that you think sets our team apart as really sort of this dynamic, sort of caregiving component of someone's life? I mean, what is it that makes it so dynamic?
Oh, wow. I think what makes it dynamic is the fact that we're following that patient. We're helping them. Um, we're helping them on the plan that they set forth when they chose hospice. And when you're able to work together with your colleagues in different professional backgrounds, you're able to meet every aspect of that patient, the whole well-being of the patient.
Yeah. So is it fair to say that the diversity of the group of people, the team that are taking care of the patient, sounds like that's actually what makes it truly dynamic, right? That's really what makes it function. Is that a fair statement?
It is.
Yeah.
Yes.
So, you know, it's interesting. I want to go back to something we talked about early on in this conversation when you identified that the patient needed a volunteer, or really the patient didn't need a volunteer, the caregiver needed a volunteer for respite. And you've hit on this a couple times, that you're listening for things that people are saying, right? But it sounds like you're also picking up on the things they're not saying.
A lot of times you do.
Yes. So what might some of those be? I mean, we talked about the volunteer, but what are some of the other things that you can think of readily?
Well, just for an example, I had a patient that had COPD, and I had been seeing this patient for a while, and I would always see her in the morning. She liked the morning routine. She was always dressed, ready for the day when I got there. So I got to noticing that she was still in her pajamas when I would come in. So, I got to exploring that a little bit just in casual conversation. I mean, and so I found out that she wasn't getting ready before I got there because it was taking her so long to actually do her bathing and getting dressed, because her breathing was that bad and she was having to take so many rest breaks. And so then I was able to talk with her and add an aid to that to help her out so that she could do more of the things that she wanted to do rather than spend it all on getting ready for the day.
Wow. And just by sheer observation, I mean, that led you down a path of conversation with her. You found this out because clearly she was perhaps maybe not going to share that with you.
No, she would not.
Yeah, I mean, that's interesting. And when you say when you say aide, you're talking about a certified nursing assistant.
Yes.
Yeah, like a patient care
And
technician.
they perform the personal care for, they help them.
Sure. Um, is it fair to say that patients and families don't always know what they want when they when you're first meeting them? Are they do they not always know exactly um, what they're looking for, or and certainly they don't perhaps know what it is they need to know, right? And so you're assessing that too, I suspect.
Yes, I do. Um, there's a lot of times just being able to sit and talk with the patient, because when I make my visit, this might explain it a little bit better. So when I make my visits usually lasts 45 minutes to an hour.
Okay.
And after I do my physical assessment, full body assessment of the patient, then I'm, putting in vital signs in my computer. And during that time, a lot of families will open up and they'll talk more. And a lot of times they'll even say, "Oh, I forgot to tell you about this. This happened the other day." So you actually have a lot of time there to learn a lot more. And so during that during that time that I'm there, the patient may be talking to me too. And a lot of times when the caregiver goes out of the room, they open up and they share a little bit more with me as well. And for instance, I had a patient that, you know, he was on this path to the end of life, and it was important to him to teach his wife how to run the lawnmower. Something as simple as that. But that was one of his goals, and he didn't even know it. So once we got his pain managed enough where he could get outside and be able to teach her how to run the lawnmower. So, goals don't have to be big. They can be just something simple that's important to you. Um, so
That's an incredibly powerful statement, Lynette. We've got a few more minutes, and I want to ask you, you know, that's a hard set of commentary to follow. I'll tell you. What are the one or two things that you really want people to know about our organization and what you do as a nurse?
I guess, well, I know that I would want them to know that hospice does not mean that you're giving up on life. A lot of times, life is happening then. A lot of memories are made then. Um, and and just because you choose hospice, it doesn't mean you're giving up. It means that you're choosing how how you want that end of life path to go. And and so when you do that, then you're just opening up the doors for this team that's here to help you on that path. You're guiding us into what's important to you to help you through that. And then I would want you to know that you don't have to be alone in this process, not like I was. Um, with the care and support of a hospice team behind you, it can help promote a better quality of life. And when you have a better quality of life, you're able to make those lasting memories that your family will remember.
It reminds me of something that I say a lot um, about not only just what we do, but I think it's a, a true statement about life. When we feel better, we live better. And that's part of it. Sounds like you've confirmed, certainly for me, and probably a lot of folks who are listening to this today or listening to this later or watching it later, that's what we do. We help you feel better in order to live better. And for whatever period of time that might actually be. Lynette, I see that Ryan Biagini has joined us back again, which means we are really out of time. I will tell you, on behalf of the 232 team members of Hospice of the Piedmont and our affiliate organization, Hospice of Randolph, it has been my privilege to have this conversation with you. It's such a powerful and very impactful conversation that it truly was. And I really do appreciate this opportunity to have spent about 45 minutes learning more about who you are and what you do, and having you tell about your experiences to folks who are interested in being connected with our organization. So I sincerely appreciate that. And I'll turn it back over to Ryan.
Yes, let me just echo that thank you to allow us to just kind of sit in on this discussion as flies on the wall has really been special. One of the things that has continued to stand out to me the most from these E-Series conversations is just how well the Hospice of the Piedmont team works together to support the patients and the families that they serve day in and day out. I really love the stories you shared, Lynette, of how you pull in social workers, chaplains, CNAs, even volunteers to provide the best holistic, I think that's the word you used, care possible for those receiving our services. Your passion for your work, for the patients and the families that you serve, and for the team kind of serving alongside you in the trenches, all of that came through so clear in this 45 minutes. So, what a gift to our families and to the communities we serve. And again, thank you for what you do and for taking this time to speak with us. I also appreciate each one of you listening in with us today, and hope you enjoyed this time, but would also hope that you join us for the E-Series as it continues. Our next webinar, Conversations in Care, Setting the Goal, will be on Friday, December 4th. During that discussion, Trent will engage our organization's medical director on how understanding a patient's needs, wants, and priorities is essential in hospice care, and how the medical team supports individuals and their families. Registration for that webinar is live now under events on the Hospice of the Piedmont website, and I hope you will join us. Lastly, if you have enjoyed this session and would like to share it with others, you can find this E-Series webinar as well as all of our previous webinars that Trent alluded to in his discussion with Lynette on the Hospice of the Piedmont website under resources. Again, thank you for being with us today, and I hope you have a great day.